Poliomyelitis is a highly infectious viral disease that primarily targets the nervous systems of children under 5. While global vaccination efforts have been extensive, the wild poliovirus remains actively endemic in parts of Pakistan and Afghanistan. Wild poliovirus type 2 and type 3 have been eradicated globally, leaving type 1 as the sole wild strain actively circulating in endemic regions today. This stripped-down, unenveloped architecture allows the virus to survive for weeks in contaminated water and endure the chemical journey into the human digestive tract. The poliovirus enters the body primarily through the fecal-oral route. In areas lacking robust sanitation, the virus spreads when drinking water or food becomes contaminated with human feces. This schematic tracks the ingestion process. As the virus reaches the stomach, it encounters gastric acid with a pH as low as 1.5. Because the poliovirus relies on its tough protein capsid rather than a fragile lipid envelope, it passes through this acidic environment completely intact. Once in the digestive tract, an infected person becomes a carrier. They harbor the virus in their throat for up to 2 weeks and excrete it in their feces for 3 to 6 weeks. Crucially, they shed the virus even if they remain entirely asymptomatic. Though less common, viral transmission can also occur through direct person-to-person contact, spreading via saliva and respiratory droplets. Poor hygiene conditions allow a localized gastrointestinal infection to scale into a continuous, community-wide public health threat. Inside the host, the virus targets the mucosal cells of the oropharynx and the small intestine, specifically clustering in Peyer's patches. Peyer's patches are masses of lymphatic tissue found in the lining of the small intestine. Here, the virus rapidly replicates. From the mucosal lining, the newly formed viral particles drain into the surrounding immune infrastructure, collecting in the deep cervical lymph nodes of the neck and the mesenteric lymph nodes of the gut. This buildup triggers viremia. Viremia is the presence of viruses in the blood, marking the moment the pathogen spills out of the lymphatic system and enters systemic circulation. In most individuals, the immune system detects the circulating virus and neutralizes it. But if the immune response fails to clear the blood, the virus continues to multiply. This cross-section shows the critical failure state. The circulating virus breaches the blood-brain barrier, the selective border protecting the brain, and descends directly into the tissues of the spinal cord. The moment the virus crosses from the blood into the central nervous system, a mild gastrointestinal infection shifts into a neurological crisis. This diagram of the spinal cord isolates the anterior horn. This specific region houses the network of lower motor neurons, the nerve cells responsible for transmitting movement signals out to skeletal muscles. The poliovirus exhibits a high degree of viral tropism. Tropism refers to a virus's affinity for a particular type of host cell. Polio uniquely recognizes and binds to receptors on the surface of these lower motor neurons. Once inside, the viral RNA hijacks the host's ribosomes. The neuron is essentially repurposed into a virus factory until the cellular membrane ruptures, resulting in cell lysis and death. When the motor neuron dies, its attached axon is permanently disconnected from the target muscle. Without the electrical impulses required to stimulate movement, the orphaned muscle fiber immediately loses function and begins to atrophy. The microscopic destruction of individual cells in the spinal cord translates directly to the sudden, irreversible physical paralysis observed at the patient's bedside. Despite its reputation, between 70 and 95% of all polio infections are completely asymptomatic.
Roughly 4 to 8% of cases develop into abortive poliomyelitis. This presents as a self-limiting illness characterized by fever, headache, and fatigue, resolving without lasting damage. Another 1 to 2% progress to non-paralytic poliomyelitis. Patients experience the symptoms of aseptic meningitis, including severe headache and neck stiffness, but they do not experience muscle paralysis. In less than 1% of infections, the disease presents as paralytic poliomyelitis. This is marked by the rapid onset of acute asymmetric flaccid paralysis, often leaving one limb severely weakened or immobile. A critical clinical hallmark is that while the patient suffers total motor loss and absent reflexes in the affected limb, their sensory function remains intact. The virus targets motor pathways, leaving sensory neurons untouched. If the paralysis is confined to the limbs, it is classified as spinal polio. However, if the virus ascends to the brainstem, it causes bulbar polio, destroying the cranial nerves controlling the diaphragm and leading to acute respiratory failure. The specific clinical severity a patient experiences is a reflection of exactly how many anterior horn cells the virus managed to destroy before the immune system intervened. For suspected cases, the gold standard for clinical diagnosis is a stool sample test. Using reverse transcription polymerase chain reaction, or RT-PCR, lab technicians look for specific poliovirus RNA within the 3 to 6 week window of fecal excretion. If central nervous system involvement is suspected, a lumbar puncture will reveal an aseptic meningitis profile in the cerebrospinal fluid, specifically marked by normal glucose levels and an increased lymphocyte count. If the diagnosis is confirmed, clinicians face a harsh reality. There is no approved antiviral treatment or cure capable of reversing an acute poliovirus infection. Medical protocols are strictly supportive. Management consists of analgesics to control muscle pain, mechanical ventilation for respiratory failure, and physical therapy for bone deformities. Modern medicine cannot save the infected neurons. Intervention is entirely restricted to managing the physical fallout of irreversible neurological damage. Even those who survive and regain function face a secondary threat known as post-polio syndrome. This is a delayed complication that typically strikes 15 to 30 years after the initial recovery from paralytic polio. Patients experience a new onset of muscle weakness, extreme fatigue, and a progressive return of muscle atrophy. During the initial healing process, surviving motor neurons sprouted new axon terminals to re-innervate the surrounding muscle fibers that had been orphaned by the virus. Decades later, these overextended motor neurons reach a state of metabolic exhaustion. The demand of maintaining so many extra axon terminals causes the neuron to degenerate and fail, leading the muscle fibers to atrophy once again. Post-polio syndrome is not a reactivation of the virus. It is the mechanical failure of a severely compromised and overworked neurological network. Because there is no cure, the global medical community relies on a single strategy: primary prevention through mass vaccination. The Sabin oral polio vaccine, or OPV, uses a live attenuated virus. Administered as liquid drops, it replicates in the gut to provide mucosal immunity. However, because it sheds in feces, it carries a rare risk of mutating into a vaccine-derived poliovirus in under-immunized populations. In contrast, the Salk inactivated polio vaccine, or IPV, is administered via injection. Because it relies on a killed virus, it cannot cause the disease, preventing systemic paralysis without the risk of mutation. To recap, poliomyelitis is caused by an enterovirus, transmitted primarily through the fecal-oral route. Its definitive clinical hallmark is the rapid onset of acute asymmetric flaccid paralysis with completely intact sensation. It is diagnosed by isolating viral RNA from a stool sample via PCR, and survivors remain at risk of post-polio syndrome decades later. The destruction of the anterior horn is permanent, and once the paralysis is established, modern medicine cannot reverse it. In the absence of a cure, relentless public health prevention remains the only effective response to the virus.